folding, but you have cytoplasm. This is why it throws you off. Because in the small cell, you don't see cytoplasm. That's the nuclei hug each other. We call it molding. But in the large cell neuroendocrine, you see cytoplasm. But you always think about there is large cell and small cell. So look more here. This is high power. But the look from low power, if you practice your eyes, go low power, high power for the junior and for the trainee in the room. Low power, high power, and you pick up an image in your head about neuroendocrine. And it's the same in the lung, in the cervix, anywhere. The look the same. And I put few images. What would I do? Chromogranin? Beautiful. Synaptophysin? What else would I do? CD56. Always. Okay? I didn't put pictures, but you do CD56, P63. You might see geographic tumor necrosis. You would see nest with focal glandular. Very good. There is a glandular configuration. Yes, it's here. Nest with focal glandular configuration, trabecular pattern, so it's always there. And if you see the glandular configuration, do not, always keep thinking about it. And the small cell, no cytoplasm. It's busier even. And if it is staying well, you won't see that smudgy, we see it at the edge of the line because the biopsy is so small. But if it is fixed well, you won't see that. And it's a full section, remember? It's at the edge you would see that smudgy looking, and only if it is small biopsy. Cytology, sometimes you don't see that smudgy look. So, salt and pepper chromatin, there is no nucleoli. Look at that look. In the small cell, you do not see the nucleoli. You might see it in the large neuroendocrine. Okay, what else? Numerous apoptosis and mitosis. And it is HPV 18 and 16. If it is large cell or small cell, both, they do bad. Okay? And these are the different, like the markers that we use. You don't have to use them all. Think about TTF1 might be positive, so you cannot say this is primary lung or primary cervix. It could be primary cervix. And again, you throw it to the physician. They should do their homework. Okay? HER2/neu, 50% of cases are positive as well.
In the cervix?
Yeah.
But not in the lung. So when HER2/neu is positive, this is cervical.
One more time.
HER2/neu is positive in cervical neuroendocrine.
Yeah, but it could be in the lung. I don't know the literature in the lung. HER2/neu could be positive in so many other tumors. Yeah. So neuroendocrine can be part of a mixed carcinoma, squamous cell and neuroendocrine. You might see keratin curls. You might see endocervical adenocarcinoma. Next, do you remember my previous slide in the first lecture? Next to small cell, you could see it in squamous cell carcinoma. It's here. So the mixed, again, just be aware of that. CD56 might be very helpful, okay, because chromogranin might not be all the time positive. Again, adenocarcinoma and mixed, and small cell, so it's in the mixed, and we do the three. This is the best scenario when you do chromogranin, synaptophysin, and CD56 together. Unfortunately, it goes to the brain. Okay? This is brain mat. This is a brain material, and it goes in. More geographic, this is more in the brain. P63 negative, because this is your differential diagnosis, chromogranin positive. So it is neuroendocrine carcinoma. It's very high aggressive tumor. And the differential diagnosis of squamous cell. What did I put? Apparently, I liked that one so much that I loaded you with pictures. Adenosquamous carcinoma with basaloid features. So this is CK56 and and this is focally P63. So the previous case was fully differentiated carcinoma, basaloid type. This one, here, I just put. Okay. My second case, third case. This is a little bit 30 years old, unfortunately, and that was my case, and I honestly was stunned over this case. It's a long story, but this patient, during her surgery, she lost her insurance. So first when she came, she's 30 years only. She came with 9 centimeter fibroid, left ovary was not visualized well. It was very small, okay? DNC was a typical complex hyperplasia with squamous differentiation. They gave her progestational therapy. Right? She's very young. She wants to serve her fertility. And apparently it did not respond to progesterone. So she kept having that typical complex hyperplasia and a background of secretory endometrium because of the progesterone. She scheduled for surgery, however, she canceled and lost follow-up. And the real story was because she lost her insurance. Later on, look at the difference, probably 6 months, she came to the emergency room and she increased abdominal pain, nausea, vomiting, and they thought about treating a bladder infection, but the CT of the abdomen revealed left adnexal mass, 14 centimeters. Look at it from here, she had no ovarian mass to 14 centimeters. All right? So I was the lucky one to get the case. So in the intraoperative finding, we have 15 centimeter adnexal mass. Uterus, we had the fibroid. Right ovary was normal, was only the left ovary. She had a lot of carcinomatosis everywhere. And extensive retroperitoneal lymphadenopathy, that threw me off. Like lymphadenopathy was there. And I got so many phone calls about this patient because she was so young and the presentation was very bizarre. Frozen section, I got malignant neoplasm. I couldn't, honestly, I could not classify it. And let me show you. I want to go more through this. That was her ovarian mass. Literally. So you tell me, what's your differential diagnosis? What do you want to rule out? She's 30, with very rapidly growing mass. One at a time. Can you speak up?
Germ cell tumor?
Very good, germ cell tumor. What else? It's too bizarre. I would think about some bizarre granulosa cell tumor because it's unilateral. That's very good that it is unilateral. I would think about sex-cord stromal tumor. You know which one is the worst one? We thought about it. It is the poorly differentiated sex-cord stromal tumor. Might present like this. But it's, it's in the differential, the poorly differentiated one. It's in the same category. What else? Poorly differentiated carcinoma, simple as that, absolutely. What else? Lymphoma, because remember the lymphadenopathy, lymphoma. How about melanoma? Think always melanoma, right? Okay, so that was what in my head, germ cell, lymphoma, melanoma, some bizarre undifferentiated carcinoma, or sex-cord stromal tumor, some poorly differentiated one. Because it's unilateral, she's young, so you always think about germ cell and sex-cord stromal tumor. I don't know how much money we spent over this case. This is her, the ovary. But do you remember in the endometrium, she has a typical complex hyperplasia with squamous differentiation. We bump it up like few foci was endometrial adenocarcinoma. But we submit the entire endometrium. There's nothing more than that. So I asked about the differential diagnosis. You all said it right. That was my differential diagnosis. Poorly differentiated carcinoma, primary or secondary, some metastasis from somewhere. Undifferentiated carcinoma, lymphoma. Oh, I'm sorry, I forgot to tell you, high-grade sarcoma. That helioid She's 30, but you never know. Poorly differentiated sex cord stromal tumor and germ cell tumor. We did all of this antibodies. Literally, this is real. You know, we did all of these antibodies. And these are the negative. The positive were some keratin, CAM 5.2, CD15 focally, didn't tell me anything. Vimentin, if you throw it on my skin, might be positive, doesn't tell you anything. Chromogranin, very few foci, chromogranin and synaptophysin. So I'm like, I was puzzled. So I'm like, you know what, I'll give up. I'm calling it poorly differentiated carcinoma. And start digging in the literature. So what does it mean for this patient? She has endometrial carcinoma so well differentiated that even I was hesitant to call it. I called it a typical complex hyperplasia with squamous differentiation. And the ovary went crazy. So what's that? Apparently, I was not by myself. In the literature, they call it de-differentiated. The term de-differentiated was described first in soft tissue tumor. Remember the lipoma, the liposarcoma was de-differentiated part. In the endometrial, in the Mullerian system, the endometrial, sometimes you might have in the uterus and in the ovary synchrony, both positive. Both have malignancy, especially in a background of endometriosis. And apparently the ovary did the de-differentiated part and went crazy. Okay? So this is what we end up calling it. De-differentiated carcinoma arising in a background of low endometrioid carcinoma with squamous differentiation. I shared the case with Dr. Esther Oliva at Harvard, Mass General, and she agreed with me. We end up presenting the case at Bangkok in the International Academy of Pathology. And I was puzzled. And apparently these patients, they are presenting with mismatch repair MSI, you know, and this is what, I mean, I won't worry you more with the whole thing about it, but you might see very rare, less than 10% neuroendocrine features, and this is why the chromogranin and the synaptophysin was focally positive. And the incidence is very, very rare, vanishingly rare tumor, but it occurs. And Dr. Robert Soslov from Sloan Kettering, he was one of the pioneers describing it in a larger series. And this is like that you might see them both in the endometrium and in the ovary at the same time. So they can be in the endometrium, be differentiated, or the other. And DNA mismatch repair gene is present in 40%. What else would I tell you about this? A woman with synchronous primary cancer of the endometrium, do they have Lynch syndrome? They could. So why it's important to recognize this? Because the low-grade endometrioid carcinoma in the endometrium or the synchronous with ovary have excellent prognosis, but the poorly differentiated will drive the prognosis. It's not the endometrial carcinoma. And it has a very poor prognosis. So that was the diagnosis. The last one. Yes, 2 primary, synchrony. No. Okay. If I can beat them with my voice, it's 43 years old woman with chief complaint of uterine bleeding and abdominal pain and discomfort. Biopsy followed by TAH. And she had a huge uterine mass. And your differential diagnosis? This is my patient. This is after fixation. That was fresh. Okay, is it benign? Is it malignant? Raise your hand. Guys, you're tired and I'm tired. Stay with me, right? Okay. Microscopically, do I have to tell you anything about the story? So, what's your diagnosis? Leiomyosarcoma.
Leiomyosarcoma?
Yeah. Leiomyosarcoma. And what do I need to call it leiomyosarcoma? To have a classic leiomyosarcoma, I need 3 things. Significant cytologic atypia from low power. Low power. Mitosis. The cutoff 10 You don't have to count them. You have to look at them and say, yes, I have mitosis everywhere. And tumor necrosis. Tumor necrosis is the nightmare, I believe. Because if you have tumor necrosis with one of the others, you got the diagnosis, leiomyosarcoma. You don't have to have the three. Necrosis is very important, but it has to be coagulative tumor necrosis. And let me show you a few slides. It has to be tumor necrosis. The tumor necrosis, usually it's viable, around the vessels there is malignant cells. Okay, it's spared. If you think about the hyalinization, it's very confusing, but it takes over everything. It takes over even the vessels. But the tumor necrosis, it spared the cells around the vessels. And it has sharp, as if you can draw a line here. It has a sharp demarcation. There is no, what do I want to call it? Like, there is no transition, okay? Cellularity, very high, significant cytologic atypia, and you got the tumor necrosis. So you need to have three of them. Okay. It's the most common sarcoma among young women, 5-year survival from 25 to 75. It's really bad, very aggressive. And frozen section in smooth muscles, you have to see three of them. I go to my ABC whenever I have any tumor in the frozen section. Do I have the mitosis? For sure. The significant cytologic atypia. The growth, it's very soft tumor. It's not like rubbery, the same as the leiomyoma. The infiltrative, the margin, it's not smooth anymore. It's more infiltrative. I cannot read the margin very well. So put it all together, the growth and the histology together. Oh, so this is the three thing. The difference between hyalinization, infarction, infarct type versus the tumor necrosis is very important to differentiate between both of them. And sometimes can be very tricky. And this is again where I show my cases. And this is hyalinization. It's granulation tissue. This is what I want to say. That transition to the normal, we call it granulation tissue transition. You see few blood vessels, you see few lymphocytes, neutrophils sometimes, so it looks different. Okay, so note the preserved of the blood vessels in this is malignant. This is the coagulative tumor necrosis. So the blood vessels are spared most of the time, not all the time. And it cannot get more ugly like this. Whenever you have the necrosis, you have the ghost cells, we call it. They're there, they're ugly, but I cannot see them well. We call them the ghost cells. And this is the difference between the coagulative tumor necrosis and the hyalinized necrosis. It's the abrupt, the blood vessels that spared, the nuclear in the necrosis might be pale or mummified. Factors used to assess leiomyosarcoma: the age of the patient, tumor size, appearance of the cut surface, the invasion of the tumor margins, I depend a lot about it, vascular invasion, cytologic atypia, mitotic index, and the coagulative tumor necrosis. Immunohistochemistry, it's very debatable in the literature. EMA and keratin, CD10, WT1, ER, PR, AR, P53, P16. Honestly, what I do caldesmin, E-caldesmin, active, and sometimes my differential diagnosis in the cellular leiomyoma, not leiomyosarcoma. Think about endometrial stromal cell. Okay? And so that caldesmin, leiomyosarcoma, and CD10 might be three of them, in both positive. So the prognosis is always the stage. It's a bad tumor, and it is bad prognosis. And I will not give you a headache about the other variant of it, the myxoid and the epithelioid. It's another game. Okay? And it's leiomyosarcoma. How I'm doing with the time? You want one more? Or you? Yes? Well, raise your hand if you want one more. Okay. We'll go one more. It's interesting. This last one is actually interesting.
So we have three to go back to Alexandria.
Please go ahead.
Thank you very much. Thank you very much.
The last one. This patient was, by DNC, diagnosed as endometrial adenocarcinoma. I got the DNC. The patient went through hysterectomy. Okay? In the hysterectomy, frozen section diagnosis, there was no tumor. That was her DNC. It was like atrophic polyp. In the polyp, we got serous carcinoma. In the hysterectomy specimen, there was no polyp, no mass, no carcinoma. So what would you do? You submit the entire endometrial cavity, entirely. We call it with red low fit. So literally, you go very thin. You don't have to go deep, the full section. No. We go superficial, but we submit the entire endometrial cavity. There was no tumor, literally. So, what would we call it? No residual tumor, you see. I'm sorry? Yeah. So my point in this last case, not only in serous, we looked at 15, was it 15? It was more than 15. I think 25 cases, okay? And DNC was diagnosed as either serous or endometrioid carcinoma in the endometrioid FIGO grade 3 or FIGO grade 1. But in the hysterectomy specimen, we didn't see any malignancy. I'm sure most of you, probably, you encountered one or two, but there was nothing in the literature about this. What's the follow-up on this patient? Were they treated or not treated? So this is what we did. Okay, we looked at, I believe, 23 cases. Okay, if you look at this, we looked at 23 cases. The majority was 12 cases FIGO 1, 2 FIGO 2, 1 FIGO 3, serous we had 6, 1 intraepithelial, 1 clear cell. Some of them, they did chemotherapy, the serous, of course, because some of these physicians might be from a different school of thoughts that they think that they have to treat this patient. Some of these patients went through lymphadenectomy, but most of them, they did wonderful, except one case, the patient died of disease. So my point in this, and this is my last slide, I don't have to, go through the entire study, that, they have to be followed up closely, this patient. You don't lose them that, oh, you are cured. It depends about the carcinoma that they had. If it is serous or high-grade endometrioid carcinoma, they need to be followed up closely. And that was my last one. We call it vanishing endometrial carcinoma. It's in the American Journal of Search Path. Okay? Absolutely. The ovary, in serous carcinoma, we examine the ovary entirely.
Thank you very much, Professor Ruba, for your nice interactive lectures, and we appreciate your attendance till 5 o'clock. Thank you very much.